The National Health Service is the largest civic project in British history. Its original specification, the NHS Constitution, guaranteed a universal network of care owned by the public. It placed a strict, non-delegable duty on the government to secure safe treatment for every citizen. But an independent, citizen-led audit of forensic financial data, coroner reports, and regulatory filings reveals a massive product deviation. The system is operating entirely outside its original blueprint. The exact point of failure traces back to a specific legislative event, the Health and Social Care Act of 2012. That act legally severed the Secretary of State's operational duty to actually provide health care. Instead, accountability was fractured and dispersed across dozens of autonomous local commissioning groups and independent trusts. By removing the single executive owner of the end-to-end patient journey, the state created a lethal accountability vacuum. When patients cross from one regional boundary or hospital trust to another, nobody is legally required to ensure they survive the trip. Without a unified chain of command, regulators have to rely on crude performance league tables to manage the chaos. The result is a phenomenon called steering failure. These centralized dashboards reward throughput. They track how fast beds empty and how quickly waiting lists cycle, crushing critical safety metrics in the process. Hospitals secure their fund patient stability. This pressure forces administrators into metric gaming. A common tactic is the hello nurse, where staff are assigned strictly to greet arrivals within a mandated target window. It stops the clock on the dashboard, satisfying the regulator, while the patient sits in an observation ward receiving absolutely no clinical intervention. This is a chart showing suicide rates per 100,000 people in England and Wales. Notice the sharp, sustained escalation immediately following the 2012 structural reforms. Complex patients with chronic needs drag down throughput averages. They become metric liabilities. Under pressure to clear beds, hospitals prematurely discharge high-risk, unstable individuals into a fragmented community care system. The NHS is not failing to meet its performance targets. It is succeeding at them. The metrics actively incentivize speed over survival, converting vulnerable human beings into disposable data points. This relentless friction destroys the workforce. Clinical burnout is heavily documented, but it is routinely misclassified as a lagging human resources problem. It is actually a leading indicator of systemic collapse. The degradation is nonlinear. When exhausted nurses and doctors leave, their caseloads are instantly transferred to the clinicians left behind. That compresses the time available for safety-critical tasks, forcing staff to compromise their own medical ethics to hit administrative throughput goals. The government's current solution to this crisis is another massive reorganisation, absorbing NHS England back into the Department of Health and Social Care to cut bureaucracy. This is a false fix. It pulls operational control directly into a political office, exposing medical planning to short-term election cycles. Crucially, it does absolutely nothing to reinstate the Secretary of State's legal duty to provide care. Shuffling the management chart without repairing the constitutional foundation guarantees the accountability vacuum will remain wide open. We do not need to wait for a new act of Parliament to stop the immediate bleeding. The Health and Care Act of 2022 already contains massive unused powers of intervention. The Secretary of State can mandate MOUs to establish strict rules for continuous coverage. It is illegal to discharge complex patients until the next provider takes over. These MOUs force data sharing. Failed transitions trigger immediate alerts to a central regulator, preventing fatalities. This is an emergency triage mechanism. It immediately patches the gaps in the network and keeps patients alive while we rebuild the underlying architecture. The long-term blueprint for that rebuild already exists. It is a citizen-proposed framework called the NHS Accountability and Patient Rights Act, or NAPRA. NAPRA abandons strict throughput quotas and measures success exclusively through patient safety and continuity of care. Most importantly, it takes the moral suggestions found in the current NHS Constitution and converts them into legally enforceable rights. It establishes a patient rights tribunal with the power to penalize executives and compel real correction when care standards collapse. By installing strict executive liability, NAPRA forces the system to value human life over statistical flow. The NHS isn't a competitive marketplace, it's not a performance dashboard, and not a political asset. It is a constitutional project designed to protect the public. The evidence of its structural failure is undeniable. The required action is clear. Lawmakers must execute emergency MOUs today and commit to passing NAPRA tomorrow. It is time to audit the failure, repair the blueprint, and secure the promise that the health service belongs to us all.